Hi, good evening, everybody, and thank you very much to week 4 of our rural onboarding. We've actually had an entire month, which is quite exciting. This week is going to be on emergency medicine. As we have got the program up here, it looks like we're going to make a swap for next week's session. So the reason why we were all mysterious about our guest speaker, we had an amazing guest speaker lined up, but they got caught in the whole PEPFAR mess. And so we thought we're hoping that we'll have more clarity in whether they can come and talk to us later on. So what I'm going to do is the session that I was going to do in the last week, the supportive learning environments, which is going to be an ethics session, I will be doing the next week, and then we'll do the child health one in the last week, and hopefully by then we'll have clarity on who our speaker is going to be. But Tonight, we are moving on to a topic that probably does not get nearly enough coverage in general webinars and training. And it's one of those fields where there's probably a lot happening and nobody being aware of it, a bit like asthma as well, and some of these quite important, but not as perhaps as sexy as some of the bigger topics. And we have Dr. Cascia Day who's going to come and is speaking to us tonight, and she's one of 2 registered physician allergists in South Africa, and is currently completing a PhD on ACE inhibitor angioedema biomarkers and genetics in Africa with funding support from Discovery Foundation, and the SAMRC Bongani Mayosi Research Capacity Development Fund. So Cascia completed her undergraduate degree at Wits in 2020 with distinction, and she then completed her internship at Tygerberg Hospital and a community service at Khayelitsha District Hospital. She underwent further training as a specialist physician at the University of Cape Town in 2020, and then she went on to sub-specialise in Allergology and Clinical Immunology, graduating in 2023. So she's a member of the steering committee for the International Network of Antibiotic Allergy Nations, with a focus on penicillin allergy delabeling in Africa. And she's been the co-chair of the UCT Department of Medicine Research Symposium Committee since 2023. She's a clinician scientist with experience in both original research and industry trials at the UCT Lung Institute Allergy and Immunology Unit, with a special interest in drug allergy, infectious disease, angioedema, and urticaria. So Cascia is passionate about allergy education and improving access to care in Africa. I'm very, very excited, and we definitely have the right person to talk to us about this important topic this evening. Cascia, you're welcome to share your slides, and I'll be handing over to you.
Thank you so much, Madeline, for the very kind introduction. I just want to check if everybody can see my slides.
Beautifully, you can just put them in there. But unfortunately, there's this irritating thing with Zoom that if you, they're perfect. It's in slide view. Perfect.
Yes, I've got it in slide view. Thank you. I've got 2 screens. So thank you so much to Madeline and to the RuDASA community for inviting me to speak today. As Madeline has said, this is a topic that is often not actually taught in medical schools. And we know that globally, angioedema and urticaria is very, very poorly understood by healthcare professionals, and is a really, really important topic. And hopefully by the end of this session this evening, you'll find out why. So just to disclose, I have received funding from the Discovery Foundation and from the Bongani Mayosi Research Capacity Development for my thesis. So today I'm going to be looking at a couple of different aspects of angioedema. First things first, for rural doctors, I'm going to try and provide you some resources on how to contact us at the allergy clinic if you have any concerns. We're going to look at the definition of angioedema and its global epidemiology, as well as what's happening in South Africa. And then we're going to look at the different types of angioedema and how to actually approach them in an emergency medicine setting. And then if we have time at the end of the evening, I have a couple of interactive cases which I would love to present. So first things first, how can you get a hold of us? So the Adult Allergy Clinic at Khayelitsha is the only adult allergy clinic in South Africa. So we see patients from around the country. We've developed a couple of mechanisms to help with this. So we have developed the 24-hour South African angioedema hotline service, and you can see a poster with it over there with the number. We provide 24-hour service to around the country, and I'm very proud to say that we have actually provided care for patients in rural Eastern Cape and KZN. So please save this number. If you're ever stuck or if you have a patient that you don't know what to do, please give us a call. For these patients that are outside of the Western Cape and outside of our drainage area, we also have telemedicine available. And we have, in conjunction with HAE South Africa, developed the Sinovoyo South Africa Virtual Angioedema Center, where if you can find computer and internet access at your facility, we can then do a telemedicine consult with you and your patient and provide any additional information or any additional help that may be needed. Finally, if you are in a facility that uses Vula, we are on the Vula mobile app. If you look under Curtis Hospital, we are under Allergology. You are more than welcome to refer us patients here. And we're also very, very happy to provide advice and further guidance via this app service. So, what is angioedema? Angioedema is a sudden, pronounced swelling of the lower dermis and the subcutaneous or mucous membranes in an individual. And why is angioedema so tricky? The problem is that there are different types of angioedema, and they all look almost exactly the same. So if you look at these 4 images, you'd say to me, how on earth am I going to tell if this is mast cell-mediated angioedema, drug-induced angioedema, or bradykinin-mediated angioedema? And just to give you a little bit of idea, this is one of our HAE patients. So you can see he's got marked swelling of his lower lip and his face. This is another HAE patient who's developed unilateral limb swelling. This patient had a reaction to non-steroidal anti-inflammatories with large lips involved in the lower left. And then this young boy in the top left actually had an allergic reaction to peanuts. So as you can see, the pathology is quite different, but it can present in a very similar way, which can make it quite tricky to manage as a junior doctor and in an emergency situation. So hopefully I'm going to provide you some tips and tools during this talk that you'll be able to use. So what are the different types of angioedema? There is a new classification of angioedema that's recently released, but I will leave that to the allergists and the urticariologists. And for your understanding, you need to know that there are 3 types of angioedema. The first type of angioedema is bradykinin-mediated angioedema. And this can be further subdivided into hereditary angioedema, which is a common condition that I'm going to be spending a little bit of time on this evening. Drug-induced angioedema, which is a huge problem in South Africa. Acquired angioedema, which is as rare as hen's teeth, but it is something that you need to be aware about. Mast cell-mediated angioedema is the type of angioedema that everybody thinks of, first off, when they see someone presenting with swelling. And this is angioedema that's precipitated by mast cells and is typically IgE-mediated. These are usually patients who have a sensitization to an allergen, for instance, bee venom or peanuts or cow's milk. And once being exposed to this allergen, they then develop angioedema because of mast cell degranulation. Finally, we have idiopathic angioedema. Now, this is a very frustrating group because in this group of patients, we can't be sure whether they have bradykinin-mediated or mast cell-mediated angioedema. And again, this is something more in the realm of the allergist, but it is a concept that you need to understand so that you can make referrals appropriately. The most important thing to know about these different types of angioedema is that the treatment is different, and this is vital when you're sitting in an emergency situation. So what is the epidemiology of angioedema? Unfortunately, like I've said, it's not very well described globally, and we know that it accounts for 0.1 to 0.4% of all emergency room visits globally, and it's the 2nd most common cause for acute allergic presentations to the emergency room in the USA, exceeded only by asthma. We also know that for some reason, it disproportionately affects African Americans. But the problem is angioedema has only been studied in African Americans. And to date, there is very little data on angioedema from African patients. We also know that from global studies, the hospitalization rates in the USA have increased over the last decade. And it's thought that this is due to increased rates of hypertension globally and increased ACE inhibitor prescribing. If you think about previous ACE inhibitor cases that you may have seen in your emergency room or in your practice, it has this interesting phenomenon of clustering, where we tend to see no patients for months and months on end, and then all of a sudden, in a 2-week, 3-week period, you'll have 10 or 15 presentations. And there has been some research which links these possible clustering events to pollen in the atmosphere, particularly to tree pollens and then to the weed pollens. And this is something that we are looking at in our patients. But all well and good, how does this translate to a South African context? So we wanted to investigate this. And in 2022, we did a retrospective folder review we screened 818 events from the HECTOS system that were coded as acute allergy presentations for a 2-year period from June 2018 to June 2020. And we looked at 4 different facilities: Cascia, George Regional Hospital, Mitchell's Plain District Hospital, and Haydenveld EC. So these were facilities across different drainage areas, and there were some primary facilities, some district hospitals, and some tertiary facilities in here. We then focused in on the Cascia and Mitchell's Plain patients because we were able to get that information, and we identified 231 adult events of angioedema, of an allergic, severe allergic reaction, sorry. And of these 231 presentations, almost 65% of them presented with angioedema, which equated to 1 to 3 acute angioedema cases per facility per week. So this is not a rare condition. This is something that you will see regularly in your practice. So what did we find? Very interestingly, we found that the causes of angioedema were predominantly drug-induced angioedema. However, something that was also very interesting was if you combine these lower 3 groups, anaphylaxis, acute allergy, and angioedema with urticaria, these would be defined as mast cell-mediated angioedema. And if you look at the numbers, this accounts for 48% of the presentations, whereas the drug-induced and hereditary angioedema in our context accounted for 52% of the presentations. So this is just a little bit more evidence about why you need to understand the differences between these 2 types of angioedema and how to manage them in an emergency setting. And interestingly, we seem to have much higher rates in South Africa of bradykinin-mediated angioedema than in other countries overseas, where mast cell-mediated angioedema is the predominant problem in emergency centers. So we went and dug a little bit deeper into these drug-induced angioedema cases, and we found that 68% of these cases, so 27% of all of the acute angioedema presentations to these emergency rooms, were due to ACE inhibitors. There was a rather large contribution from non-steroidal anti-inflammatories and antibiotics, and then the other section included miscellaneous drugs, including contrast media. So a little bit more in this study. It's a common emergency. We also, as I've said, found that bradykinin-mediated angioedema in our context was more common than mast cell-mediated angioedema. And in these patients who reported ACE inhibitor angioedema, 22 reported recurrent angioedema, and none of these patients were referred for allergy services or for further investigation. Another interesting fact is the majority of acute angioedema in these patients involved swelling above the shoulders. And there was airway involvement in 22 patients, with 2 patients requiring intubation. Overall, 14 patients were admitted and there were no deaths. Interestingly, in the patients with bradykinin-mediated angioedema, 36% of them were incorrectly treated with steroids and antihistamines. And this is in a high-functioning district and tertiary hospital setting, which is quite scary to think of. Finally, if you have a look at the pie graph on the right-hand side, you can see that just over a quarter of the patients required high care or ICU admission, but a very large percentage of these patients actually overnighted in the emergency room and they were discharged later on. So these patients not only are common, they are not being treated correctly, but they also place a huge strain on our emergency room staff. So why is this a big issue? And you can imagine that behind the scenes, people were asking, is angioedema actually an important topic to discuss in rural medicine? And yes, it is. Let's just look at ACE inhibitor angioedema. The 2022 census in South Africa found that we had a population of 63 million, with 41 million patients people being over the age of 19 years. We also know that in South Africa, 1 in 3 adults has high blood pressure, which equates to 14 million patients with hypertension, of whom at least 10 million are using enalapril. And if we think about the risk factors for ACE inhibitor angioedema, typically they say about a 1% risk in a non-African population. We're looking at 10,000 cases per year. But in patients with African ancestry, 3 to 5% develop ACE inhibitor angioedema. So you're looking at least 50,000 cases per year in the country, which works out to over 4,000 cases per month. The mortality rate in ACE inhibitor angioedema is 11%. There is no diagnostic test and there is no targeted treatment. So this is something that we have to understand and something that we have to know about so that we can manage it appropriately. So let's start with angioedema history. There are a couple of red flags in history that you need to be aware about. The first red flag in someone who presents with angioedema without urticaria is weight loss. In these patients presenting with angioedema without urticaria, you need to start looking for a non-benign lesion. Patients who have joint pain, muscle pain, or any additional skin signs also need to raise red flags because these patients may have systemic disorders that are causing the angioedema. Finally, if the angioedema is localated to a single anatomical site, so as you can see with this young man here, he has marked swelling that's fixed and is not reducing on the left side of his mandible. Very, very, very important to exclude non-benign lesions. Finally, if the patient has angioedema without urticaria for a prolonged duration with no resolution, typically over 3 days, you need to start having red flags thinking, is this something else? Is this hereditary angioedema? There are a number of mimics of angioedema as well that I'm going to quickly go through, so you have a brief differential diagnosis when you are seeing these patients. The first thing you need to think about is infection. This image comes from a lovely pimple popping website, and it's pimple popping gone wrong. This is cellulitis, and as you can see, this patient has quite a bad infected pustule here on her neck, on her forehead, which has resulted in marked swelling of the forehead and the eyes. The next thing you need to exclude and think about is infiltrative diseases. So the first thing to think of is thyroid disease, where patients develop proptosis, but it's important to remember that they can also develop angioedema around the eyes. In IgG4 disease, which is also an infiltrative disease, and granulomatous disease such as sarcoidosis, these patients can also present with angioedema mimics that look like swellings, but these swellings will typically be fixed and will not resolve and be in one anatomical location. With regards to immune-mediated causes that can mimic angioedema, you need to be aware of dermatomyositis and SLE. If you can have a look in this picture, this is a woman who presented with angioedema to our allergy clinic. And if you have a look, you can actually see that this angioedema is quite biolaceous. And this was a patient who was later diagnosed with dermatomyositis. Finally, again, you need to think of malignancy, particularly if the patient has a history of weight loss or if they have fixed swelling in a particular anatomical location that does not resolve. You also need to think about angioedema in the context of another disease. So let's first look at dermatological diseases. Contact dermatitis is incredibly common, and we see it very, very often in patients who are using hair dyes. So this is a patient who used a henna-based hair dye that had PPD in it, and she had severe contact dermatitis with marked angioedema of the lids, as you can see. Morbus morbihan is a very rare complication of rosacea, where the patients can have asymmetrical fixed swelling in the face and require specialist treatment. These patients typically will have long-lasting swelling that doesn't resolve. Some vascular causes you need to think of include superior vena cava syndrome, and this patient was a patient in ICU who had a clotted JVP, and as you can see, this patient has developed marked swelling and plethora of the face, but there are also some tips and tools here to look at, and you can see that this patient would have a positive Pemberton sign, and they've also got quite markedly dilated varices across the chest and in the neck. Another one to think of here is thoracic outlet obstruction, which can present in a very similar way. One of the rare causes of recurrent angioedema without urticaria is papillary leak syndrome, which is a very bizarre syndrome where the patients will come in with gross angioedema in cardiovascular shock. And it's a condition that is very rare, but does occur, and it needs to be on your differential. Finally, you can have patients with idiopathic angioedema, so cyclical angioedema. These are typically women who get angioedema during or in and around their perimenstrual period. It is an incredibly frustrating condition to treat and is quite common and is something you need to be aware of as well. So let's now look at bradykinin-mediated angioedema. So bradykinin-mediated angioedema, as the name implies, is caused by increased levels of bradykinin. Now, this can either be from overproduction of bradykinin. So the bradykinin production is usually mediated by C1 esterase, which is an enzyme that helps with the production of bradykinin. And if C1 esterase is inhibited or is blocked, there is a subsequent overproduction of bradykinin. It can also be due to inhibition of bradykinin degradation. So there are a number of enzymes that break down bradykinin, including your ACE, nephrolysin, DPP4, aminopeptidase, and carboxypeptidase N. And if any of those enzymes are malfunctioning, you will have an accumulation of bradykinin in the system, and it will result in angioedema. So bradykinin is a vasoactive peptide. and increased bradykinin levels result in vasodilation and fluid extravasation into the tissues. Importantly, very importantly, bradykinin-mediated angioedema is not associated with urticaria. And again, I'm going to highlight this. Bradykinin-mediated angioedema has not got any history or any signs of urticaria. So this is a beautiful diagram that was produced by Prof. Peter, which looks at the breakdown and the pathways of bradykinin. And we're going to start at the top up here. Unfortunately, I don't think I have a, let me see. Okay, sorry, I'm just going to get spotlight. So if you have a look here, we have high molecular weight kininogen, which is acted on by kallikrein to form cleaved high molecular weight kininogen and bradykinin. Bradykinin then acts either on the bradykinin 2 receptor or the bradykinin 1 receptor, and it's broken down by all of those different enzymes, carboxypeptidase, ACE inhibitor, the angiotensin converting enzyme, neprilysin, APP, again, angiotensin converting enzyme, neprilysin, DPP4. Now, why is this important? Because a number of drugs can block this pathway, including ACE inhibitors, the new ARNIs or angiotensin receptor blockers with neprilysin inhibitor, which is a new drug that is being used in patients with cardiac failure. And as you can imagine, you're now not only blocking the angiotensin receptor, you're also blocking neprilysin. So these patients theoretically have a much higher risk of angioedema than with ACE inhibitors alone. We then also have the DPP4 inhibitors, which are, in inverted commas, one of the novel, or not so novel, as they're about 15 years old now, diabetic agents that we are starting to see being released into the private sector, and there are some patients getting it in the state sector as well. So these are very important drugs to be aware of because these drugs can potentially change your bradykinin pathway. And as we've seen now, drug-induced angioedema, and specifically ACE inhibitor angioedema, is the most common emergency presentation of angioedema in South Africa. So it is something you need to be aware of. Another one that you need to be aware of in terms of drugs is non-steroidal anti-inflammatories. Interestingly, non-steroidal anti-inflammatories is not mediated by mast cells or IgE or by bradykinin, but it's actually because of its COX-1 inhibition. So it's another very important point to remember. So why is bradykinin-mediated angioedema important? So let's look at first at hereditary angioedema. So hereditary angioedema can grossly be divided into two groups. HAE with a low C1 esterase. So if you go back to this diagram, you can see C1 esterase or C1 inhibitor works here, and it inactivates factor 12 and also inactivates prekallikrein. So by inactivating, you're going to decrease the kallikrein and decrease the bradykinin production. So if you don't have this enzyme, you're going to have overproduction of bradykinin in your system. So these patients with HAE can either have a low C1 esterase, which would be low in numbers, so quantitative, or it's not working, so it's low functional value, or they can actually have a normal C1 esterase. It's vital that these patients are diagnosed because they need targeted therapy. They do not respond to antihistamines and steroids. In HAE, if the patient is untreated in an airway attack, the mortality rate is 40%. These patients are incredibly scary to manage when they're having airway attacks. And the very scary thing is that a patient's first airway attack or laryngeal attack can occur at 40 years of age. Also, patients with HAE can have a laryngeal attack out of the blue. Having had a previous laryngeal attack does not increase or decrease your risk for further laryngeal attacks. And this is something that we've been having to deal with our pharmacy to try and motivate for a drug called icatibant, which you can see over here, which is the drug that's used to treat acute hereditary angioedema. Another very, very important thing to remember if you have a patient with hereditary angioedema is that all family members must be screened. Hereditary angioedema is an autosomal dominant condition. And if you know that autosomal dominant means there's a 50% chance that your child will have the condition. So the screening must be performed to identify patients in that family who are also at risk for HAE. Screening is very simple. It's done with a complement 4, a C4, and a C1 esterase level. There are some very important questions to ask that can help you identify patients who may have possible HAE. The first thing is a family history of angioedema. So remember, it's an autosomal dominant condition, but 25% of patients will have a de novo mutation. So family history is there in 75% of patients. A history of abdominal swelling is a red flag for hereditary angioedema. Drug-induced angioedema and mast cell-mediated angioedema will not cause abdominal or genital swelling. These patients also typically have a very early age of onset. In South Africa, our youngest patient began swelling at 2 years of age, but I know overseas the youngest patient that they've had start swelling at 9 months. So it's not just a disease of adults, it is also a disease of children. Another important red flag to think about HAE is patients who have a duration of swelling that lasts longer than 48 hours. Typically, mast cell-mediated swelling will resolve within 24 hours. So if you have a patient that has swelling that's lasting 48 hours or longer, you need to think bradykinin-mediated angioedema, exclude hereditary angioedema. The other form of bradykinin-mediated angioedema, as I've said, is acquired angioedema. It's very rare. It's caused by an autoantibody to the C1 esterase protein, or that C1 esterase synthesis can't keep up with C1 esterase destruction. Typically seen in autoimmune disease and in patients with malignancy. It's important to note for the malignancy because the angioedema can precede the malignancy by up to 10 years. This is a table looking at the different investigations that you can do to identify patients with hereditary angioedema. You can see that there's hereditary angioedema type 1, where the actual amount of the C1 esterase is low. There's type 2, where there's a normal amount of C1 esterase, but a decreased C1 esterase function. And then there's this rare form of HAE type 3, where the patients will have normal values for all of these markers. Patients with drug-induced angioedema will also have negative markers here. They will have normal C1 esterase function, a normal C4, and a normal C1q, and they will not have anti-C1 esterase antibodies. We're now going to be moving on to mast cell-mediated angioedema. So mast cell-mediated angioedema very commonly occurs with urticaria, or it involves other organ systems like cardiovascular, respiratory, and GIT systems. If it involves other organ systems in the patients presenting with urticaria and angioedema, it's anaphylaxis and needs to be managed as such. I've put 2 images here on the right-hand side, and these are patients from our clinic. As you can see, we've got one patient with pale skin and one patient with dark skin. Typically, urticaria is described as a erythematous papule that's raised and is non-blanching. But if you have a look at the differences between these 2 skins, you can see that the urticaria that's seen in pale skin is a lot redder and easier to see than is in darker skin. So this is just a recommendation to be very careful when you're looking for urticaria in patients with probable mast cell-mediated angioedema. And it's often actually easier felt than it is seen. So, as I said previously, mast cell-mediated angioedema is the most common cause of acute allergic reactions. Something you do need to be aware of, though, is if the mast cell-mediated angioedema and urticaria lasts for longer than 6 weeks, you need to consider a diagnosis of chronic spontaneous urticaria. Mast cell-mediated angioedema can occur without urticaria. International data shows that 10% of patients with CSU have associated angioedema, but we know from our recent research that in South Africa, 65% of our patients with CSU have associated angioedema, which is incredibly high. And so it is something you need to consider. Very importantly, mast cell-mediated angioedema responds beautifully to corticosteroids and to antihistamines, and that is the mainstay of management for these patients. Idiopathic angioedema, as I've said, is angioedema without urticaria, for which a clinical or laboratory cause cannot be found. It's rare. It occurs in between 10 and 40% of patients with recurrent angioedema without urticaria. And there is some research now showing that these cases actually respond to omalizumab. So is this an angioedema only CSU variant that we're missing? But this is something that, as I said, is more in the allergist's realm, and it's beyond the emergency EC. So thanks, Cascia. That's all well and good. But what do I do in casualty, and why is it important? This is why it's important. You do not want to reach this point with your patient in casualty. As you can see, these are both patients who have severe angioedema of the airway. And as you can guess, intubation in this case is going to be almost impossible. And this is what we want to try and avoid. So let's look at clinical features. So histamine or mast cell-mediated angioedema can present with swelling of the lips and the tongue. They will have urticaria and itching. They can have laryngeal swelling, facial swelling. but it's typically rapid in onset. So remember that it's usually after an allergen or after an exposure to an allergen, and it occurs within 1 to 6 hours as rapid onset. They respond beautifully to adrenaline, to corticosteroids, and to antihistamines. There may be nausea and vomiting, particularly in the context of a severe anaphylactic reaction. And again, these patients can have multi-system involvement with hypertension and shock and anaphylaxis, as well as wheeze and anaphylaxis. Bradykinin-mediated angioedema, again, presents with swelling of the lips and the tongue, so there's a little bit of overlap. Again, presents with laryngeal swelling, so overlap, but they are more likely to have swelling above the shoulders, so facial and shoulder swelling. They're more likely to have abdominal pain and are more likely to have abdominal swelling, peripheral swelling, and genital urinary swelling. So that's really important clinical pearls to try and determine what type of angioedema these patients have. Now, I know this is a little bit of a busy screen, but I'm going to go through it with you step by step. And this is an algorithm that we developed for the management of angioedema in an emergency center in South Africa. So your patient presents with angioedema. What is the most important thing you need to see? Think about those two images I showed you just now. Is the airway secure? If the airway is not secure, you call for help, follow your difficult airway algorithm if you have one at your facility, and containing the airway is, once the airway is secure, they can then continue the algorithm. In facilities where you're lucky enough to have an airway team, this is where you call them in. In other facilities, this is an ideal place for fiber optic intubation or for intubation with a glide scope. If the airway is secure, you can then move on with the algorithm. Is there multi-system involvement? So urticaria, bronchospasm, hypotension, nausea and vomiting, and abdominal pain. If the answer is yes to any of those, this patient must be treated as anaphylaxis per algorithm. We also recommend doing a mast cell tryptase test in these patients because it allows us to see if it is actually mast cell mediated. Prior to discharge, these patients must be referred to an internist or an allergist. They must be prescribed adrenaline, and they must be given an allergy action plan. Remember that prescribing adrenaline and giving an allergy action plan to a patient who has had anaphylaxis or life-threatening angioedema is the job of the doctor in the emergency center. And there have been court cases where clinicians in the emergency centers have not prescribed adrenaline and patients have died. So it is a very, very important point to remember. Next, if there is not multi-system involvement, you need to then establish diagnosis. First question you need to ask yourself is, are they taking any medication? Now think of all those medications I've listed: ACE inhibitors, DPP4 inhibitors, your ARNIs, and your ARBs. If they are taking one of those drugs, then you manage them as bradykinin-mediated angioedema. So you stop the drug and you replace it with an alternative agent. Consider bradykinin 2 receptor antagonists such as icatibant or recombinant C1 inhibitor Ruconest if you have it available in your facility. If you don't, you can use FFPs or freeze-dried plasma as needed. Also remember to take a C4 as a screening test in these patients, because right now you're not 100% sure, is it ACE inhibitor related? Also remember that in patients with hereditary angioedema who are given an ACE inhibitor, they can present for the first time with swelling at this point. So it's very, very important to take a C4. If they are taking medication and they're taking NSAIDs, then you treat it as mast cell-mediated angioedema with antihistamines, corticosteroids, and adrenaline if required. And again, prior to discharge, these patients must be referred to an allergist or internal medicine and must also be prescribed an adrenaline vial and given an action plan for allergies, and if possible, a medical alert bracelet. If the patient is not taking any medication, you need to ask yourself if there is underlying pathology, like an autoimmune disease or malignancy. And if there is, you need to say to yourself, this could be a possible acquired angioedema. And again, this must be treated as bradykinin-mediated angioedema. So if you have any queries about this, please put them into the chats or in the comments, and we can talk about it afterwards. Remember that we are always here and available to help. When in doubt, please contact the hotline. One question that I always get asked by clinicians who want to stop an ACE inhibitor for ACE inhibitor angioedema is it safe for me to put this patient on an angiotensin receptor blocker? Now, this is a little bit of a tricky question because 17% of people who have ACE inhibitor angioedema will have angioedema to an angiotensin receptor blocker. So I always say to clinicians, you need to look at your patient. Do they have transport? Can they get to a facility rapidly if they develop angioedema again? And is there a safe alternative agent such as a calcium channel blocker? So just remember those fact when you're looking at re-prescribing a different antihypertensive. So again, the airway in these patients is what kills them. Some of the things you need to remember is that any swelling that occurs in front of the teeth, so no soft palatal involvement, intubation is not imminently required. If the patient has swelling behind the teeth, so in the larynx or in the hard palate, you need to be very, very, very careful and observe this patient very closely because imminent intubation may be required. Some risk factors and some interesting facts is that incidence of intubation requirements in angioedema increases with age, and some risk factors that can make airway difficult are age, obesity, diabetes, and a poor malempathy score. The airway can be difficult in these patients. Remember to call for help and prepare a surgical airway if needed. Do not try and get away with a non-surgical airway. If you need a surgical airway and you need to get front of neck access in these patients, do it as soon as possible. And remember that the gold standard for severe angioedema of the upper airways is actually awake nasopharyngeal intubation. So if you look at this and you're in a rural facility where you don't have access to a glide scope or to a surgical team that can assist you with the front of neck access, you urgently need to get this patient into a facility where they can provide this care. So let's now look at the medications that you can use for histamine or mast cell-mediated angioedema. If the patient has multi-system involvement, it's anaphylaxis, treat it as anaphylaxis. In the absence of anaphylaxis, no adrenaline is indicated for non-life-threatening symptoms. So please don't give patients IM, IV, or nebulized adrenaline unless their airway is about to close. H1 antagonists and oral corticosteroids, antihistamines and oral corticosteroids can be adequate treatment. Remember that second-generation non-sedating antihistamines, so Phenergan is our usual culprit, if not urgent, be very, very careful with them because they can also drop your blood pressure. And that can sometimes muddy the water with regards to, is this actually anaphylaxis? Is this just angioedema? So be careful with Phenergan when you're prescribing it for these patients. As I've said already, patients who have life-threatening angioedema, mast cell-mediated angioedema, or anaphylaxis need to be provided an adrenaline pack or an adrenaline auto-injector and an anaphylaxis plan before they leave the emergency center, and they need to be referred to an internist. If you have it available, consider a mast cell tryptase test, because this can be very valuable in identifying what the cause is and what the type of anaphylaxis is. And something that you can remember for yourself and for your patients who have this condition is antihistamines treat hives, adrenaline saves lives, because people will often reach for the antihistamines before they reach for the adrenaline. So what do I mean by an adrenaline pack? Now, this is my MacGyver adrenaline pack that we provide. Unfortunately, EpiPens are not on code in the state sector. And if you do get them in the private sector, they are very expensive. You're looking at about 1,500 Rand per EpiPen. So it's not financially viable for a lot of patients. What you can do is you can provide the patient with 2 ampules of adrenaline, 2 syringes, and 2 18-gauge needles to draw up and to, 22-gauge needles to draw up and to deliver the epinephrine. But you need to also give them training on how to actually deliver the adrenaline safely into the intramuscular area and when to do it. So how do you do that? If you have a look on the left here, you can see the Allergy Foundation of South Africa has developed an anaphylaxis action plan. This document is amazing. It should be printed out and available in every EC because it allows you to show the patient exactly what a mild reaction is and how to treat, what a severe reaction is and how to treat. And it also provides emergency numbers for local ambulances. These are also very, very helpful if you have a child who's having a food allergy or food anaphylaxis, and it's a very useful document to keep in schools as well. I have included the web address for this document. It's freely available online. So let's move on to the medications and treatment for bradykinin-mediated angioedema. Let's start with ACE inhibitor angioedema. As I've already said, there is no treatment that is targeted for ACE inhibitor angioedema. So you need to protect the airway and observe them. So supportive management only. There have been some clinical trials looking at icatibant, the bradykinin 2 receptor antagonist, in ACE inhibitor angioedema, but unfortunately those results are conflicting, so it's not yet recommended as first-line treatment. But you can use fresh frozen plasma and freeze-dried plasma if you are in a bind and these patients are swelling and you can't get the swelling down and it's progressing. Again, there is no role for antihistamines or corticosteroids in these patients. What about patients with hereditary angioedema? First things first, ask the patient. I can guarantee you that our patients with hereditary angioedema will know more about hereditary angioedema than the clinicians will. We also try and make sure that all these patients have a wallet card, which provides information about what treatment they can get and what treatment is available. There is also increasing availability of targeted therapies in South Africa. So we have icatibant and Ruconest available at Cascia Hospital. In my experience, unfortunately, it's not available at other facilities, and it's actually not available in private either. So if you do have a patient with HAE who does not have on-demand therapy available with them, because we typically actually give this on-demand therapy to our patients to take home to use in case of an emergency, you can use fresh or freeze-dried plasma. Initially 1 to 2 bags. People always ask me about tranexamic acid in ACE inhibitor angioedema and hereditary angioedema. We don't use it as acute management. It's actually used as a prophylactic measure in these patients with hereditary angioedema. So there's no role in acute attacks for tranexamic acid. So this is just an image of what different treatments are available. So this is Ruconest, which is the C1 inhibitor concentrate, which is interestingly made from the milk of genetically altered rabbits, which is quite fascinating. And it's an intravenous injection over 5 minutes. This is icatibant, and icatibant has revolutionized the treatment of HAE. It's a prefilled syringe with 3 mils that the patients can take home. It doesn't need to be kept in a fridge, and they can give it to themselves as soon as they have an attack. And this actually allows them to treat the attack at home and to not come into hospital if they are having a severe attack. And then finally, FFPs. Now, there's been a lot of work with FFPs, and about 10 years ago, there were concerns that giving FFPs to patients with hereditary angioedema would actually precipitate anaphylaxis or worsen their attacks. And Prof. Peter did a study in South Africa and Iran, and they proved that FFPs were safe, the infusions were short, and the mean hospitalization in South Africa was 36 hours, but somehow in Iran, they got it down to 5 hours. With all of these patients, only 5% of them had a transfusion reaction, so this is safe. What about FFPs versus icatibant? So this is just a costing estimate that I've put together, and it's something that you could potentially show your unit managers. Icatibant in the state sector costs 6,000 Rand per dose. However, if you look at 2 units of FFPs, plus a cross-match, plus 1 after-hour fee, and 1 night in the ward or a high-care unit, you're looking at almost 10,000 Rand just for that admission. Whereas you could have given the patient icatibant to take home and treat themselves immediately. And as you can see, the cost in private is even higher, almost 11,000 or 12,000 Rand for an admission for 2 units of FFPs, whereas the patient could have been given icatibant at home. Is there any place for a diagnostic test in the emergency room setting in a patient who presents with bradykinin-mediated angioedema? None are very helpful acutely, but if you do a C4 in these patients, it can be very, very helpful later on for the clinicians managing them because it has a more than 98% negative predictive value for hereditary angioedema. Why should we be doing C4? So there was actually a study done in Hungary where they looked at 150 ACE inhibitor angioedema presentations. And just by doing C4 screening, they were able to identify 2 patients with hereditary angioedema. And then because of tracing, they were able to identify a further 12 family members. They also identified 3 patients with acquired angioedema. So this is not rare, and it is something that could definitely benefit the patient in the long term. What about cost? The cost of a C4 by the NHLS is 140 Rand. And if you put into perspective, a full blood count is 250 and a full LFT is 800. So it's an inexpensive test that can be done during this time that can help identify patients with hereditary angioedema. So I'm now going to be switching over to our, for the last 15 minutes, to my, sorry, I'm just trying to see where I'm going here. I'm going to be switching over to Mentimeter. So I'm going to ask if everybody can please scan this QR code. I just want to check, can everybody see the Mentimeter?
I saw it 2 seconds ago and then it vanished. It was there a minute ago.
Okay, let me just try it as a
your article summary page.
Can you see it now, Madeline?
We are seeing one of your other pages. We're not seeing
Okay.
your
Let me just try again. Sorry, everybody, for the technical glitch.
your,
Just 1
your
second.
page. But it was there for a brief second.
Okay, can everybody see the Mentimeter page now?
Can see that, yes.
Okay, great. So I'm going to go into presentation mode. So please scan the QR code and let's see if we can get some interactive case studies going. So I'm just going to give another 30 seconds for people to scan the QR code. Great, and we're going to carry on. So the first case I'm presenting is a woman who I saw in the allergy clinic. She's 35 years old. She's had recurrent episodes of angioedema without urticaria since the age of 15, affecting the lips, the tongue, the periorbital area, the hands, and each episode is long, lasting 2 to 3 days. She's had 3 admissions to ICU and 1 episode requiring intubation with no response to antihistamines or steroids. And information that she got from her clinicians was that she was told to avoid nuts, fish, wheat, soy indefinitely, as she had an unknown allergy. She was not on any chronic medication. And when we did a family history, she reported that her daughter was repeatedly admitted to hospital for unexplained swelling of her abdomen. So, what is the first step in investigating this patient? We open to Great, I'm seeing some responses coming through. Please remember this is completely anonymous. I do not get any information about who's filling this in. So if you're not sure, take a guess. I'll give you a couple more seconds. We've had 14 out of 70 people answer. So come on, guys, give it a guess. No one's going to know if you pass or fail. Great. So the majority of people have said C4 and C1 esterase testing, which is very, very true. If you look again at this case, she's had multiple admissions, she's had long-lasting angioedema, she has not responded to antihistamines, swelling, and there is a family history. So this woman was actually originally from the Eastern Cape, and she had moved to Cape Town, and we saw in our allergy clinic when she was referred to us, and we diagnosed her with HAE, and we diagnosed her daughter with HAE. We then went on and tried to trace her family in the Eastern Cape. And we actually, with the help of Eastern Cape clinicians, managed to screen her 2 sisters, her mother, her father, and some of her cousins. And we identified another 3 cases of HAE. Her brother, unfortunately, refused screening. And I was contacted 3 months later by the patient that he'd had his first laryngeal attack and he died. So again, just to highlight in patients who you are diagnosing with HAE, please, please, please remember to screen the family. Okay, our next case is an 83-year-old gentleman with a history of hypertension with left ventricular hypertrophy, as well as very well-controlled diabetes and psoriasis. He's had 5 years of recurrent angioedema with no urticaria. It occurs quite often, so 3 to 5 times per month, involving mostly his face and his cheeks. Each event lasts 3 to 4 days with no response to steroids or antihistamines. He's got no loss of weight and no other red flags. He has had some spontaneous events, but with those events, he intermittently develops urticaria after eating tinned tuna, but he does not react to fresh tuna. There's no family history of angioedema, but he's on a host of medications, including insulin, including sitagliptin, which for those who are unsure what it is a DPP-4 inhibitor, including metformin, methotrexate, and indapamide. So, if I can move on to the next slide. What is the most likely cause of recurrent angioedema without hives in this patient? Great, we're seeing some responses coming through. Remember, I'm not going to get this information, so please have a try and have a guess. We've got 10 out of 70 participants responding, and we've had 13 so far. And yes, the majority of you are correct. This patient has drug-induced angioedema, and he'd been suffering for 5 years on the sitagliptin with recurrent admissions to hospital for this angioedema. We stopped his sitagliptin and switched him onto an alternative agent. It's important to remember that in patients who have drug-induced angioedema with the ACE inhibitors, with DPP-4 inhibitors, and the ARNIs, they can continue to have angioedema for up to 3 months after stopping the drug. So it's important to counsel your patients about that, particularly if they've had airway involvement. So this patient had drug-induced angioedema. The little red herring or red tuna, should I say, with the tin tuna was that he was actually developing a histidine reaction or mild sthromboid to tin tuna. Just for interesting. Then finally is another case that we saw in casualty. So a 21-year-old female who was recently admitted to casualty with severe abdominal pain and swollen tender hands with a funny rash. She was assessed as having an appendicitis, but her CT scan, abdominal ultrasound, and abdominal ultrasound showed splenomegaly with ascites. She was then referred to a rheumatologist for evaluation of the rash and the joint pain. And his investigation showed a low C4, a normal C3, and all other autoimmune screening was negative. So he actually contacted us and asked for advice. And we were like, this sounds very suggestive of bradycardia-mediated angioedema. We need to make sure we're excluding HAE, but we also need to look for acquired angioedema in this patient because she's presenting with splenomegaly and ascites. She also had a history of one previous episode of hand swelling. So the investigations that we did in our clinic showed again a low C4. She had a low C1 esterase, a low CQ, and negative autoantibodies to C1 esterase. And she had, this is the rash that she presented with. I'm sorry, it's not her image, it's an image off the internet. But as you can see, it's a very lacy rash, and this is erythema marginatum. So what is the interpretation of this patient's blood results? So again, she had a low C4, low C1 esterase, a low C1Q, but negative autoantibodies to C1 esterase. Okay, we've got one brave person saying acquired angioedema, one person saying HAE with low C1 esterase. Come on, guys, give it a go. I promise we'll go through the algorithm again if people are a little bit confused. Okay, so I'm going to take you back to the algorithm. The correct answer is this patient had acquired angioedema because she had a low C1Q. Remember that in acquired angioedema, only 50% of those patients can have a low C1 antibody or C1 antibody, autoantibody. So I'm just briefly going to take you back. This is not a slide that I showed, but this is a flow diagram for an approach to patients with recurrent angioedema without urticaria. And let's just briefly go through for this patient. So she had recurrent angioedema without urticaria. She was not on medication. She did not have, but she did have a mimic of arthropathy. She did not have a family history of angioedema. She did not have abdominal swelling. She presented in her 20s. And the angioedema duration was long, it was more than 2 days. So more likely bradycardia-mediated, but less likely HAE, but we're obliged to test for it. So she had a low C4 and a low C1 esterase. Low C4, bradycardia-mediated angioedema. You then move on to C1Q testing, and she had low C1Q testing, so she has an acquired C1 esterase deficiency. And we need to look for autoimmune disease and hematological malignancy. And very interestingly, this patient actually had a splenic lymphoma. So thank you, everybody. That is the end of my presentation. And I'm going to stop sharing now. And we can see if anybody has any questions. You're more than welcome just to unmute yourself and ask a question, or you're welcome to put questions in the chat. I see that Santos Singer is asking for the recording. The recording will be available on YouTube. And then someone was answering a C4 and drug-induced for the other patient, which was great. So there seems not to be any.
Let me just say thank you very much. That was amazing. I think I learned vast amounts of things, and I certainly have never requested a C4 in my life before. So I assume that's available in the NHLS across the country.
Yes, it is.
Okay, so that's actually something, a really, really interesting learning point, and especially also in our emergency unit. I really like, we will definitely download that that little kit that you recommend and get our heads around actually giving patients something before they leave the ER department. So that's a sort of a few key messages that I've taken away from this training, and has found it very, very useful. So yes, if there are people who would like to comment or questions, I'm going to launch the poll. So this is just a HBCSA CPD requirement. is to make sure that we know who was actually in there. So please fill in the poll. If you can't, for some reason, access the poll on your device, please put your name and your MP number in the chat so that we can pick you up. The same for those of you that might be on YouTube. No, we're not doing YouTube. We don't have to. We've got enough space for everybody. So please just put your MP numbers in if you can't do the poll. Otherwise, it's very important for us to be able to show the HPCSA that we've evaluated everybody, that everybody's had an opportunity to evaluate tonight. I'm just checking in the chat if there are any questions. So yeah, so there's a question here. A patient with facial swelling, can't we intubate? Santos, do you maybe want to unmute and just say what your question, just clarify your question?
Hello?
Yes, Santos, go ahead.
Yes, I was asking a patient with angioedema, and clinically you see that the patient having that fast swelling of the lips and face, all those things, and to prevent any airway obstruction, can we intubate this patient to protect the airway?
Yes, definitely. So if you think about that algorithm that I showed you, that's always the first question is, if a patient's got angioedema, is the airway secure? If the airway is not secure, you need to intubate and you need to protect that airway. So it's very, very important to make sure that you're comfortable with these intubations. They can be very tricky. If you have access to a fiber optic or to a glide scope in your facility, that is helpful. If you don't, and you are worried that this patient is on their way to intubation, you need to make sure that you get them to a facility where they do have the ability to intubate this patient rapidly. Otherwise, you need to monitor that patient very, very, very closely and do regular check-ins. And if you are concerned that they're starting to deteriorate, rather intubate sooner than later, because you don't want to be stuck having to do a front of neck access in these patients. Santos, was that, hope that answered your question.
Yes, thank you.
Sure. Anybody else have any last questions they'd like to ask?
And then just a reminder, we will be sending out tomorrow the resource packs for emergency medicine. And Dr. Day is going to send me various things to add into that. So we'll add the angioedema hotline number to that, and we'll add links to some of those great resources that she shared as well. So that will all be part of that. And then the presentation will be uploaded and be available on the YouTube channel. Great. I don't see any other hands at the moment. So I think we've done excellent on time. We're right bang on 7 o'clock. Thank you very much, Dr. Day. I would actually love, we're doing RAMP webinars, sort of a monthly webinar once rural onboarding is finished, and it will actually be lovely to have a talk specifically on allergy, which is another area that's quite neglected in terms of teaching. So
Yes,
I hope we can call on you again. I think that'll be very helpful to have a practical approach with our resources to patients that often presents with urticarias, and it's very difficult to figure out the cause quite often. So I think having a talk on allergy will be very, very helpful.
Very happy to do that.
Excellent. Thank you. Great. As there's no other questions, I think I'm going to end and close the meeting now. I'll keep the lines open for a couple of minutes for those of you still doing the poll and or need to put their MP numbers in the chat. Otherwise, thank you very, very much, everybody, and have a lovely evening. I've mentioned earlier that next week's talk will not be on pediatric TB, because we are trying to sort out with the PEPFAR mess when our presenter can actually assist us. So next week we'll be doing the ethics talk about how to create supportive learning environments, and we're particularly going to talk about the toxic workplace and how we can counter that. Good night, everybody, and have a lovely evening.